absolutely. So thank you for joining us today. Thank you all for joining as well. So we are lucky to have Eileen Dacy with us here. She is in Massachusetts, so East Coast time, but she's going to talk to us about hoarding, possession hoarding specifically. She has an area of interest in research related to animal hoarding, so if that's something we have additional questions about, she might be able to entertain some of those as well. But she's a social worker, and is gonna give us some information that hopefully will help clients that everybody's kind of working with. I'll turn it over to you, Eileen.
Okay, I will share my screen to prepare a brief, sorry, here we go. I prepared just a brief PowerPoint presentation. Okay, so, what am I doing? Here we go. Sorry, one moment. How do I get it to start playing for me? Oh, present, here we go. I'm on a different computer today. All right, so I prepared a PowerPoint today, and as Jessica mentioned, the content of what I'm sharing is going to be very specific to hoarding disorder, possession hoarding in particular. I did include a couple of slides on animal hoarding as well, just to provide some background information. I work as a therapist, as a clinical social worker here in the state of Massachusetts. I also do some policy and legislative work in relation to hoarding disorder throughout New England. So I've helped establish the first legislative proclamation here in our state proclaiming Hoarding Disorder Awareness Week. And I'm doing a lot of other legislative work in relation to animal hoarding in particular. And I'm a PhD student in social work as well. So this PowerPoint is going to be very clinical. It's more clinically based rather than research based, because I try to think about, well, what sort of material or information will you be able to take away and utilize within your work, or as you start to conceptualize cases or think about assessment, planning, and even next steps, okay? So for today, in terms of the agenda, what I hope to do was to just provide a pretty good overview, but rather basic overview of hoarding disorder. So it's my belief that then you'll walk away from today's presentation with at least an understanding of what hoarding disorder is, what it looks like, and also what are the various variables that maintain this rather complex behavior. I'll chat about some assessment tools and provide links as to how you might be able to utilize those as well, how you might be able to think about clinically engaging with someone, or also switching gears if there's crisis. So there's a difference in terms of approach. And I'll share a couple of resources, and I've allotted some time at the end for question and answer. I like to make my presentations in general rather interactive, so I will ask questions as I go on to see if I can get some engagement from attendees. And at that point, I'll ask you to either unmute yourself or even write something in the chat box as well. But I want to start with, this is more of a rhetorical question, but why hoarding? Why was I invited today to talk about this particular phenomenon? It's starting to gain a lot of traction within our society. A lot of folks are interested in knowing more and trying to understand, why is it so complicated? What makes it so difficult for individuals to let go of possessions or even make decisions regarding possessions? And I would say that perhaps in summation, we could start with the prevalence of hoarding disorder in particular within our country alone. So according to the literature, we see that hoarding disorder can affect anywhere from up to 6%, so 3 to 6% of the US population. I want us to think about that for a moment. 3 to 6% of the US population. That's roughly 1 out of every 20 people in this country is struggling with some form of hoarding behavior, whether diagnosed or undiagnosed. It's roughly suspected almost 19 million people. Scholars do believe that this is an underrepresented amount of the actual figure, the actual percentage, however, because of self-reporting. This particular issue, hoarding disorder, carries a lot of societal stigma. A lot of folks are impacted by potential repercussions associated with it. So it's a little bit different than we might think of other mental health issues like depression or anxiety, which are becoming more normalized throughout our culture. But hoarding disorder is not just seen as a mental health issue, if it even is in the first place. There can be some concerns around what would this look like if others knew that I was struggling with this? What would that look like in terms of my housing as well? So, for instance, what if the Department of Public Health or Board of Health were to become aware of my dwelling and being cluttered? What would that mean? But if we go back to this percentage, though, something I really want to highlight is that this percentage indicates that hoarding disorder is actually one of the most common mental health issues in our country. Yet we don't talk about it enough. We don't talk about it certainly within a positive frame. There are a lack of resources throughout our country in terms of what we can offer individuals that are struggling with hoarding behavior, as well as what can we offer family members and loved ones of those that are struggling with hoarding behavior as well. No, this is not just an American issue. We do see percentages across the globe, even in developing countries. And there's no connection between socioeconomic status and the development of hoarding behavior. So we can see this particular behavior emerge in affluent neighborhoods, as well as affecting those that are living below the poverty threshold as well. So this is where I'm going to ask attendees if we can think about, and you can just provide your best guess. If you were to guesstimate, roughly what age does hoarding behavior generally start to develop for someone? So someone said 10, 4 to 5, 5, 20s, 5 to 6, 8. These are all really good guesses. 20s, teenage years, 20s, 8. Okay. All right. So those are actually really good guesses. I like to throw this in. I do presentations for a variety of different agencies and settings. And oftentimes a guess that I may get would be development later on in life. So we're thinking about older adulthood. But according to what we see in terms of data, in terms of the onset and course of hoarding disorders, that the behavior generally starts to develop in adolescence. So we can see anywhere from 11 to 15 years of age. This particular issue is considered a chronic and progressive disorder. So as someone engages in treatment, for instance, there's no cure for this particular disorder. Treatment would really focus a lot on behavior modification, implementation of skills and strategies, enhancing awareness of problematic behavior, things of that nature. But in terms of the progressive and chronic nature of this disorder, is that if it's not treated, it does start to worsen throughout the course of someone's life. So say the behavior starts to emerge or develop earlier on in adolescence. We think about what does that look like as each decade continues. So now as someone is aging and they're developing, they move out, they have their own space, they have their own finances or means, so they're able to perhaps acquire more, they may not be living with anyone else. And then by the time someone is older, we now start to think about even physical capabilities of even maneuvering throughout the space. And that would look different than, say, when someone was a bit younger. So the average age of treatment seekers is roughly 55 years of age or older. And we try to think about, well, why might that be the case? So whether it's someone who is self-presenting and indicating, you know what, I really need some help. I'm tired of living this way. I'm tired of trying the numerous tactics that I've been doing with little success. I want to understand why I hoard, and I want to try to get some skills, acquire some skills to be able to improve my life and reclaim my life again. But we also think, then what about when someone is reported or referred by someone else? So someone ages, we think about the number of resources now coming to their home, or the client engaging with other resources. So perhaps there's a case manager, visiting nurse association, even protective service worker, all of these other providers coming into the home, and then perhaps even discovering that there's a problem in place. So then connecting them with some sort of a resource in terms of beginning to start talking about hoarding. If we go back to the age, as I'm saying, the behavior generally begins to emerge in adolescence, is that it's incredibly difficult to diagnose this disorder in childhood or even early adolescence. And there are a couple of variables as to why that might be the case. We think about as a child is in their dwelling, that they would have a caretaker or guardian parent who is imposing strict rules as to how they should uphold their environment, or even cleaning up after them. And I've already alluded to the notion around finances. And then additionally, the other factor that makes it difficult is that this diagnosis in and of itself is so linked to the volume of items within a given space. So again, it's difficult to just provide a full diagnosis of hoarding disorder for someone who's a bit younger. What is hoarding disorder? I want to jump right into that. I know this is kind of a wordy slide, but bear with me for a moment. I want to provide some context that hoarding disorder, yes, is a mental health diagnosis, and it's a relatively new mental health diagnosis that was inserted in the DSM-5 in 2013. So hoarding disorder falls under the obsessive compulsive disorder, or OCD, related spectrum. So there are 5 total disorders under that spectrum, and hoarding disorder is one of them. So even though it's still considered a relatively new diagnosis, hoarding behavior in and of itself was studied for years, used to fall under the category of OCPD, or obsessive compulsive personality disorder. So if you ever look at the literature on hoarding, you might see language like compulsive hoarding, because that's what it used to be referred to as, but now it has its own distinct diagnosis and now referred to as hoarding disorder. There are 3 main components that I want us all to pay attention to of how we think about who would meet diagnostic criteria. Is that first, the person must demonstrate a persistent difficulty in discarding with, or parting with possessions, regardless of their actual value. This is really attributed to that person's very strong need or urge to save and hold on to items, or even distress or indecisiveness around what should I do with the items that I want to keep? Where should they go? Hoarding disorder, we never talk about what it looks like if someone is willing to let go of something. It's not just somebody saying, I have to hold on to every single thing that I have and I'm never letting go of anything. But the indecisiveness comes up as well, is where someone's like, I would like to let go of this thing, where I'm ready to part with this item, but I don't know how. And that makes it also very complicated. In short, as another takeaway, if you could take away from this presentation, is that hoarding disorder, there needs to be the presentation of a strong attachment to possessions, regardless of their actual value. So you can't just go into a home that's cluttered and automatically assume that the person has hoarding disorder. Is there that presentation of a strong level of attachment to a great number of possessions? Now, the second criterion is noticing, and this is going to be the most visible component of this disorder, that the symptoms result in accumulation of a large number of possessions that can congest and clutter active living areas of the home to the point of even compromising their intended use. So what I mean by active living areas, right? I mean living room, bathrooms, bedrooms, even other areas of the home, right? Garages, basements, front yard, backyard, cars. What about, are there also accompanying storage units, plural, that this person may have? Okay, so people generally focus on this point and they see large volume of possessions and automatically assume the person has hoarding disorder. And I say this because I've consulted on so many cases where it might just be squalor, for instance, or it might just be a cluttering issue. If I go into a situation and it might be a squalid situation, and the referring source says this person definitely has hoarding disorder, can you help them clinically? And then I start to brainstorm and think about barriers with the individual. And then the person says, well, I've been meaning to clean up, but I don't have the energy for it or the physical capabilities to do it or the resources. This area has just gotten beyond my control. But if you could bring someone in and get rid of everything, then by all means go for it. It's usually a bit of an indicator to say this person does not have hoarding disorder, but the squalor or the conditions of the home may be attributed to something else, whether it's a physical concern, another mental health concern, or even cognitive decline. The last component for us to pay attention to in terms of hoarding disorder is that the symptoms cause such clinically significant distress in an impairment in social or even occupational functioning. So I've already mentioned earlier on in today's presentation is that there's a huge point of societal stigma, social stigma attached to this disorder. So we try to think about, is the person now becoming a little bit more reclusive, not allowing people to come into their home because of fear of judgment or even fear of reporting, for instance. As I mentioned, I wanted to just throw in just a few slides on animal hoarding just to provide some background. Happy to chat further with you guys either at the end of today's presentation or you could even email as well. Okay, so this slide in particular just references Tufts University's first mention of starting to really focus on animal hoarding in particular. This is directly from their site. So if you're curious about animal hoarding further, curious about ways in which animal welfare, public health, even crisis management what that might look like. These folks at HARC were really the initiators of focusing on animal hoarding, but it's more of like a self-propagated site at this point. It's not well maintained, unfortunately. One of my colleagues, Dr. Gary Petronic, was the first person to operationally define animal hoarding. And animal hoarding, therefore, was inserted within the DSM-5. However, it's often overlooked, unfortunately. So I just have a screenshot here of what it would look like, right? The F code is F42 for hoarding disorder within the DSM-5. And then if you look through the DSM-5 under hoarding disorder, you'll find a very tiny paragraph, which I have here, that even mentions animal hoarding, but it really doesn't describe how this is similar to possession hoarding, how it might be different, what does this look like? But yes, it's part of the diagnosis. It's not a separate diagnosis in and of itself. So how is that defined? Animal hoarding focuses not on the quantity of animals that a person has, but more or less the quality of care of the animals that the person has. So, some people are like, well, Eileen, what if someone has 30 cats? Does that mean that they're hoarding animals? Well, if all 30 cats are well taken care of, then no. Animal hoarding does fall and constitute under oftentimes animal cruelty, and animal cruelty is a felony. So that's why there's such emphasis on quality of care. So it might be that the person has a failure to provide minimal standards of care for their animals. There could be a failure to act on the deteriorating conditions of the animals. So perhaps the animals have diseases, or they're starving, or they're in crowded environmental concerns. Maybe the cages aren't cleaned, or there's not enough space for them to move around. The person may be unaware of the negative effect of their accumulation of their animals on their own well-being, as well as anyone else who might also be residing within the home. And now we start to see a little bit of overlap with possession hoarding and animal hoarding, is that there's this consistent urge or persistent need to continue to accumulate more animals despite evident problems that are within the space. Okay, so if we go back to the diagnosis in and of itself, similar to OCD, obsessive compulsive disorder, for those of you that are more familiar with that diagnosis, we have to think about, well, what level of insight does the person present with who has the problem? Do they have good or fair insight? So there's at least this recognition that there is a problem with the behavior. Doesn't mean they're going to do something about it, but there is that awareness that's there. Or perhaps there might be poor insight. So the person might state that they don't have a problem, despite evidence to the contrary. Even more rare is going to be absent insight. So the person has more of a delusional or even fixed belief that there is no problem. They might attribute the problem to someone completely different. Again, despite evidence to the contrary. So despite that they may be facing homelessness, possible eviction, or condemnation of their private dwelling. Another specifier is if the person presents with excessively acquiring items. So not everyone with hoarding disorder excessively acquires, but roughly 80 to 90% of those who hoard will acquire items, either through active means, as you and I might, right? I have a notion where I'm going to go to a store and I want to buy X, right? I'm going to go to that store. Or even passive means, which might be someone's driving, and all of a sudden on the side of the road they spot a free piece of furniture and they think to themselves, wow, that would look great in my home. Or I know someone who would love that, right? Stealing is much less common. And I wanted to clear that up because it can be a common misconception. So we see anywhere from 10 to 15% of the population who hoards may steal, but it's important that as clinicians, we start to think about the presentation of kleptomania, for instance. So why do people who hoard refuse help? I think that that's a pretty common question, right? So if there's that stigma, or they perceive that judgment and they say, well, I'm ready to get help, then when help is provided, how come it's still so complicated? And this is where I want to get into this part of the presentation by talking about the variables that maintain this very complex disorder. We can start with thinking about the presentation of comorbidities or co-occurring mental health issues. About 92% of those with hoarding disorder also present with another mental health issue. Oftentimes, depression or major depressive disorder is the most common co-occurring mental health issue that someone presents with. Some other things in terms of refusal of help is thinking about how one defines the problem, right? And how they see the problem, how that might differ from someone else, okay? So if I try to think about maybe some of the cases that you all are working on, is that what if you came across a case, resident service coordinator is concerned about a resident who's hoarding and it's in violation of their lease, and now they're facing a potential notice to quit. So now we're thinking about eviction and how that's looming. Resident service coordinator might state that the person just needs to get rid of things, just throw everything away, or get rid of things, clear spaces, or if some of these things are so valuable, put them elsewhere, put them in a storage unit. Person who is hoarding may see that, yes, I have a problem. So say they have fair insight. Okay. I have a problem. I have a lot of stuff, and I recognize that I am facing eviction. However, I don't think it's as bad as they're making it out to be, right? Or I don't have the means to just acquire a storage unit and start placing things in my storage unit. So trying to understand, well, how is that problem of hoarding actually defined? Who's defining it? And then what do we do about it? Oftentimes, I may hear, or other providers may hear from someone who's hoarding, well, if I had more space, this wouldn't be a problem. I wonder how many of you have heard such a statement, right? If you think about older adults who have downsized, now living in subsidized housing, for instance, they're living in a smaller space than they once had, and they brought all of their possessions or the majority of their possessions with them. Sure, it looks a lot more cluttered than perhaps in a larger house and what that looked like. Sometimes folks will say, but if I had a storage unit or multiple storage units, this wouldn't be a problem. And that can be a misconception, because then it's just more space. If this is truly the disorder that they're presenting with, they can acquire more items, they can fill up their space more, despite how many more off-site storage units that you may have. Another reason for refusal of help might be fear of help and discovery. As I've alluded to earlier, is that what if my landlord were to become aware, and then perhaps they would contact the Board of Health, and then now I'm concerned about condemnation. So then we think about, what about the presentation of allowing repair workers to come in? Some people may go through extreme measures to avoid having any sort of repairs within the home, such as, what if there are plumbing issues, heating issues, gas, electric, so on and so forth, because if any repair worker comes in, they can also report, and that can be rather scary for some folks. As well as thinking about the other variables, perhaps hopelessness, or even mistrust if they've worked with people, either family members or even formal supports in the past, and those people perhaps inadvertently took control, creating perhaps some concerns for the person, and they feel like, well, how can I trust someone if they're just going to start touching everything or throwing things away or making decisions on my behalf, right? We have to think that these are people and recognize these are people that function autonomously, right? So if you go into a case with the assumption that they've never tried to work on this behavior before, either individually or with someone else, you're doing a disservice. I always ask, what have you done before, right? Who have you worked with? Even a therapist, what worked well? What didn't work so well? So then it can sort of set the tone as to how I might engage with the person a little bit later on. Okay. And then the other piece, in terms of why people will refuse help, is that I'm referencing something called the CBT model for hoarding disorders, just a conceptual map that I broke down into bullet points for us to think about. So I've already shared that level of insight or awareness into the problem can affect how someone would engage with help or refuse help, right? If someone has poor insight and they don't see that their behavior is problematic, of course they're not going to say, I need help, or I'm going to engage in help. What are you talking about? But there's also a presentation of information processing deficits for those with hoarding disorder. What that's broken down into and what that actually means is there can be true difficulties in perception, attention span, categorization, and even decision making regarding the possessions. Sometimes people wonder about memory, right? Is there the presentation of a memory deficit and hoarding behavior? Is there some sort of a correlation there? Okay. What the literature indicates is that there isn't a true link between some form of a memory deficit and hoarding behavior, but there are true links between memory competence and the hoarding behavior. What I mean by that is that someone might not always trust their memory or their ability to remember where they've placed something. So for instance, I have an important book, okay? This important book is something that I reference all the time. So therefore, I'm going to place it right here on this flat surface on my desk so that I'll know exactly where it is and I'll be able to retrieve it whenever I need it. But what happens when everything has that same level of importance? Things start to stack up on flat surfaces. So folks with hoarding disorder may avoid at times placing things, filing things away in filing cabinets or drawers or closets or cabinets because there's this fear that if it's out of sight, it's out of mind, I'll forget all about it. So taking just a professional organizational approach to hoarding disorder isn't going to help. That's part of the process, most certainly, but I see it as almost secondary, right? We have to understand what are some of the cognitive processes first, right? What are the barriers? What are those true core beliefs or feared consequences? Working through those first, and then thinking about organizational techniques. Starting with, let's create a filing system and your problems will be solved, is not going to work because the person still has that true belief that, but I'm going to forget everything. We're going to see just a repeated pattern. Another component as to what makes this disorder so complex is that the majority, and even though I don't know the actual percentage because it's not clearly articulated in present day literature, but there is a presentation oftentimes of those with hoarding disorder to have a history of trauma. What I know, at least for animal hoarding, is that there's usually a history of very complex trauma. Oftentimes, individuals will report physical trauma. They might indicate that there was a history of physical abuse, sexual abuse, or even severe psychological abuse, which then furthers that need for unconditional love of the animals. But that's an aside. So we think about if someone is struggling with trauma or someone is struggling with loss or perceived loss, what do the possessions provide for the person, right? And also, what do the possessions mean to the person? So it's not simply looking at a situation, a home, and the person says, I love everything that's within this space. Even the process of sorting through possessions can be rather triggering for someone as well. Because what if they're going through things and then they're reminded of really beautiful moments, memories, lived experiences that they had. But then what if they also encounter an item that reminded them of something very negative that happened in their past? And it could create this panic peak, and the person will say, well, I have to avoid it. Whether they say verbally or non-verbally, but they will stop the process and say, gotta take a break. This is just too much. I'm being flooded right now. There are also, beliefs, strong beliefs and attachments to possessions. We all have reasons for holding on to items. Usually those reasons are broken down into three main categories: sentimental reasons, intrinsic reasons, or instrumental reasons. So we hold on to something for an emotional tie, right? This is something that reminds me of an experience that I had. May not make sense to anyone else, but it's meaningful to me. Okay? Or perhaps holding on to something because an intrinsic reason. This item was something that the person deems as beautiful. It's artistic, it's a decoration. So therefore I can't let go of it because it's too pretty to just throw away. And then lastly, this is one of the more complicated pieces, is an instrumental need to hold on to something. So I may not have a use for this item right now, presently, but I might in the future. And holding on to that notion that I might use this again in the future, or I may know someone who could benefit from using this, will then further the notion for the person to hold on to the item just in case. I have to have those extra set of Tupperwares because what if, someone needs a to-go plate, right? So kind of thinking about those pieces a little bit further. Okay. Wanted to give you all just some pieces that if you are having conversations with your clients and you're trying to think about, well, how do we start to kind of raise the awareness or the level of insight? These are just some questions that you all can start to begin to think about or utilize. And I don't want you to think about these as the person's automatically going to have the answer. Sometimes just raising or enhancing insight, I like to think about it as like planting seeds a little bit, getting someone to just kind of ponder their behavior a little bit further or ponder their reasons for holding on to things. So such questions of, how many do you already have? Is that enough? Which is a tricky question because the person could say, no, it's not enough. That's why I keep acquiring more, or that's why I'm holding on to things. Then we start to think about usage. Do you have enough time to use it, review it, read it? Have you used this in the past year? When? For what purpose? Do you have a specific plan for this item? So sometimes I like to think about things in terms of probability. So by when, or what's the likelihood that you'll use this item again? Does it fit in with your values and needs? So starting to think about values-based decisions. Does it fit in with their values and needs? I need to hold on to this item because it's important to me. But it's also very important to the person that they reclaim their space so that they can have their grandchildren come visit again, right? So starting to think a little bit further, think a little bit more long-term. Some of my favorites are, would you buy this again if you didn't already own it? Okay, do you really need it? So thinking about need versus want. If you needed to get it again, would you be able to replace it? So also thinking about possibility of replaceability. What about when communication starts to go sour? So whether that's between you and the client, a family member and a client, or even another provider and the client, is we have to think about, well, communication, how do we just dissect that and how do we include that? Okay. So working with hoarding disorder is constantly thinking about all of the various processes as to how we might enhance or improve the situation overall. So it could even very well just start with how we even talk with the client, right? Or how we observe others talking with the client. So if I hear dialogue from a family member, a client, family members like, you always screw up, or you're such a slob, I don't know why you always do this. Why can't you just throw this stuff away? It's very you. Okay. That language is blaming, it's negative. So if someone is hearing that, think about how receptive they're going to be to that sort of messaging. They're not going to be like, you're right, I am a slob, it's time for me to start cleaning up. No, it might create some avoidance, a need for escape, perhaps even further distancing between themselves and this other person. The conversations always then end with assigning blame. So then how do we shift that? Or how can we mirror that even for family members or other providers? Is by using something called pious communication. Okay. Pious communication could be starting the conversation with a positive statement, right? I understand that some of our discussions are upsetting, but I'd love it if you could help me work them out. So it's starting to shift from assigning blame, very individualistic, it's only on that person, to now thinking about a collaborative approach. I hear you, right? And therefore, I'm wondering if we can work on this together. Shifting patterns with more I statements. I would be happy if you did not go to the rummage sale today. I feel hurt when we miss our weekly lunch together. Demonstrating understanding, again, using a lot of I hear you kind of language, which is so pervasive in social work dialogue. I understand that some of our discussions are upsetting, but I love it if we can work them out together. So very similar to earlier. Even sharing responsibility, which can be hard for family members to think about what is their role or function in the relationship with someone who hoards, right? Starting to think about, is there a piece of codependency or even enabling? I know it's partly my fault that we argue about your stuff so much. I'm trying to be more understanding, and I hope you'll try to see things from my point of view. So trying to then relay that to the person. Some helpful guidelines as you're working on a case, some do's and don'ts. Try to really provide encouragement, understanding, and belief in the person as you're working with them. Always try to highlight, what are their strengths? What are their protective factors? Think about that. Stay calm. And I try to encourage this for other practitioners, is to think about transparency. Okay. Is that people are generally pretty intuitive, and they'll notice if you're being disingenuous, right? They'll go, oh, this is so beautiful. Oh my gosh, no, this isn't so bad. Your home's great. They're going to notice that there's like this infantilizing component to what you're sharing with them, rather than emphasizing transparency that, you know, I am concerned about the way in which you're living, and these are the reasons why I'm concerned. This is what I'm noticing. Are you noticing some of these things as well? Don't do any of the following. Don't like pick up things and be like, well, why do you have this here? Can't we just throw it away? Try not to use any judgmental language, touch belongings without explicit permission. Never try to declutter behind someone's back, even though in the moment you're thinking to yourself, well, this would help speed up the process a little bit more, right? I'm working on an area, this looks like trash, I can start throwing things away, and I can create a whole nother pile of things to donate. So yes, in theory, that would speed up the process. But what does that teach the person? Think about that, right? Is that treatment focuses on implementing skills and strategies. If you're doing the work for someone, then what is going to look like when they are tasked with sorting themselves, making decisions themselves? Remember, indecisiveness is a part of this disorder that makes it complicated to move forward. And never say you're going to do something and then don't do it. So I've worked with other providers who are like, yeah, I'll donate this bag of stuff for you. I'll take it to Salvation Army. No big deal. And then they go and throw it away. So think about, what if your client found out that you did that? That could break any sort of rapport you've already started to establish with this person and can undo a lot of the work. Okay. If you don't have the time to do something, don't do it. I try to encourage, if the person is able to, that have them go and donate the stuff themselves or take the trash out themselves, so that they're getting used to that process of letting go, because it can feel rather compulsive, and that's where it becomes to sort of tie into the avoidant behavior, is actually just driving to the donation site and dropping off the stuff. And then we'll just see piles of things that are ready to donate within the hallway of the person's home, but they're not really ready to let it go. So try to really foster that point of learning, rather than them creating more of a dependence on me or another provider to get used to, oh yeah, well, when Eileen comes, I need to just take these bags of things and we'll donate it on my behalf. Okay, so let's talk about treatment practices. Okay, I mentioned that treatment, we have to think about, okay, if there's treatment and the person is ready to engage in counseling, versus what happens when there's a dire need. Okay, there's a crisis. So what we know about possession hoarding is that the validated treatment modality is CBT, cognitive behavioral therapy. There's starting to be a lot of emerging literature on the application of ACT, or acceptance and commitment therapy, in treatment of hoarding disorder, as well as compassion focused therapy as well. But as of right now, we do know that CBT can work for those who struggle with possession hoarding. I will also insert that in terms of animal hoarding, there is not a specific validated treatment modality that helps with animal hoarding. So that's just an aside. But if we think about CBT and we think about successful treatment outcomes, we have to think about, well, how a person enters into treatment and how participatory and engaging they are in their treatment. If the person is mandated to treatment and the person then is like, okay, the therapist is saying we're going to do CBT and this is what we're going to do, what does successful treatment actually look like? And what happens if a person is facing a crisis? There's a finite period of time for them to get through this period. So CBT for hoarding disorder, what we know is that we're looking at up to like about 28 sessions or so, depending on how the treatment plan is constructed. And then the person then has to focus on maintenance lifelong. Maybe they might come back for booster sessions. It's very similar to the treatment of OCD, for instance, right? But if the person doesn't have the luxury of time, and again, they're facing a crisis, then we have to think about an alternative approach. Okay, so if they are facing eviction or facing condemnation, or they're open with protective services, whatever the imminent issue is, we want to think about, okay, how do we help in a different way rather than focusing so much on just thinking about cognitive processes and modifying behavior. An alternative approach that a lot of researchers are starting to pay more and more attention to is the application of harm reduction for hoarding. So I know that you guys are probably familiar with the application of harm reduction as obviously meant a public health approach to thinking about substance use, for instance, or other areas of concern. So meaning, what is the point of this is trying to decrease any safety risks, right? Any potential harm, and try to increase the safety within a person's life scenario. Harm reduction is really thinking about and trying to pay attention to as the general tenets and principles is that every person is different and they're all driven by their own individual needs, right? And there are internal needs, so reasons why someone might implicitly want to change, and there are also external or explicit needs, right? So that might be compliance, trying to get the home up to code, for instance. Harm reduction is about meeting someone where they're at, which is a huge philosophy if we think about social work, right? How was our profession actually developed? What fuels our profession? Meeting people where they are, no matter what walk of life that they're coming from. So if we think about harm reduction in application of hoarding disorder, it's not about being 10 steps ahead of the person and then saying, hey, keep up, let's do this goal and this goal and this goal, but thinking about how do we uniquely tailor to make sure that we're fitting the person's needs. I wanted to chat about then, if we're talking about crisis, filing a protective report. Okay. I did put information here in terms of Massachusetts, but I want you to think about, as a mandated reporter, if you have to file either an adult protective report or a child protective report, what would that look like in terms of hoarding situations? If you have the ability, my strongest encouragement recommendation is at least trying to visit the residence, visit the dwelling, if you can, to have firsthand information. If you're able to provide firsthand information on a report, that makes for a much stronger report rather than secondary information. The brother of the resident told me X, right? Notice that everyone has a different threshold for clutter and a different threshold for what they might deem to be unsafe or safe. But there are some particular issues that are really going to necessitate the opening of an investigation for a protective report. So think about imminent risk. So such as, is there the presentation of human or animal waste within the space? Is the individual consuming rotting or spoiling foods? Is the person actually facing a condemnation, or have they received a notice to quit and eviction is looming? Is there significant structural damage to the space? I do follow this notion that when it comes to a protective report, I like to discuss the report with my client rather than filing it and then letting them figure it out on their own, or then all of a sudden a protective worker shows up. I discuss it, and this goes back to really emphasizing transparency, that as a manual reporter, I had to file. These were the concerns that I noticed as we've discussed, so it shouldn't be a surprise to the person. But then also thinking about setting that worker up for success, right? So trying to frame it as this protective worker is going to be someone who we can use as part of the team. These are the ways in which a protective worker could help us, so on and so forth. So it's not just another person encroaching in on their space, but really just another team member who's there to offer support. So some assessment tools for you all to focus on or can use, and I will provide these links as well, is that there are 3 major assessment tools when looking at possession hoarding cases, not animal hoarding. So when it comes to a preliminary assessment, thinking about risk, one that's widely used is called the Holmes Risk Assessment Tool. So taking a look at health complications, obstacles, mental health, engagement, structure, and safety. This particular assessment tool focuses on identifying what you notice are some of the areas of concerns, and then it prompts you to think about developing a plan. Are you then going to work with this case ongoing? Are you going to refer the case out to another resource? Are you going to become a part of the team, right? Then the other very well-known assessment tool is called the Clutter Image Rating Assessment Tool. This is not a diagnostic tool, but it's a pictorial assessment that has you go into any given room and assess the room in terms of volume of items within the space. You could also download this as a free downloadable app that is Apple compatible. Unfortunately, for some reason, it's not Android compatible. But the assessment has you think about assessing in terms of volume on a scale from 1 to 9. So 1 being minimal to no clutter within the space, up to 9 being most severe. What I like to do as another way to enhance insight is be able to show my client and be like, how would you rate your bedroom, or how would you rate this space, and describe what the purpose of this is for. Usually clients will predict about the same number that you're coming up with, or they might be off by 1. It's not going to be something that's so radically different where you're standing in a 9 out of 9 and the person says, oh, I think it's a 1. They might say 8, for instance, right? But it's pretty close. Lastly, the last assessment tool is called the Uniform Inspection Checklist, which I did help develop along with my predecessor, Marty Matthews. But this focuses on more of a harm reductionist approach. So it mirrors HUD's unit inspection. So if you're going into any given home, trying to assess it as objectively as possible. So treating every home the same. For instance, every front door should be able to open a full 90-degree angle. Okay, there should be the presentation of at least 36-inch wide continuous unobstructed pathways throughout any given residence as well. This is what housing code looks for, right? Inspectors look for this. And if they're starting to notice numerous fails, right, that's when someone is then in violation of their lease, and we start to think about how they might start to face eviction. So if we were to fix things or start to work on developing goals in terms of utilizing harm reduction approach, is how can we make it so that we have continuous pathways? So now we're just focusing on increasing that safety rather than focusing too much on changing behavior overall. Okay, let's skip through that just for time's sake here. So I just, last couple of things, I think I have about 2 more slides. I like to share these 2 sets of questions with clients when I'm initially meeting them. It can help with enhancing insight. These questions may look familiar to you because they're kind of like the miracle question, right? They're modeled after a miracle question. If you woke up tomorrow and your home is just the way you wanted it to be, how would your life be different? Not how would your home be different, but how would your life be different? Someone might then say, well, my life would be different because my grandchildren would be able to come and visit again, right? I could have space to entertain. Then I followed up with this question: what is something that you want to do that you're currently unable to do because of the clutter in your home? So we're starting to think about motivational reasons as to why someone should engage and change behavior, rather than just thinking about it through a compliance lens or thinking about it due to external needs, other people saying they need to do this, right? It's what motivates them to want to make these changes themselves. Okay. And then lastly, I just wanted to point out some resources for folks, is that there are a number of support groups across the country. Sometimes these are easier to locate rather than individual therapy. So Clutter is anonymous. It's a 12-step program, CA, similar to AA or NA. They're available for free throughout the country. Look those up online. Buried in Treasures often is a very common group model that is used, and it doesn't need to be clinician facilitated, but also peer facilitated. Sometimes they're embedded in various senior centers throughout the country. I have 2 other really great group models down below. And then I'm also referencing the book that I wrote, which is a self-help book on working with hoarding disorder, reclaim your life from hoarding. Now I want to pause and stop sharing my screen so that I can see everyone and also take a look at the chat. Okay.
Thanks, Eileen. That was great. So a lot of folks we're kind of collecting some contact information from folks. So if you have other things that we want to share out with the group, we can. So that's a lot of the messages in the chat. There was one question earlier from Emily. I don't know if you're still on, Emily. Did you feel like you got your question addressed, or do you have a follow-up or anything else to add?
Well, sorry. So my question, I guess, was related to what you said kind of towards the beginning, Eileen, of when you're trying to figure out whether somebody really is struggling with hoarding or not, and they say, oh yeah, I'm totally gonna clean this up, I just need somebody to come and help me, things along those lines. But when you come back and see them the next time and their grandson or whoever's been over and it's not any different, like they say those things, but nothing ever changes. So kind of what do you do in that case? Like it really does seem like then it's a issue with hoarding, and it's not an issue of just getting them, especially like if they're an older adult, it's not an issue of just getting them the help that they need to do the physical work.
Okay. I'm thinking out loud here, Emily, that there are a number of ways of thinking about how to approach that sort of a dilemma, which often shows up when we're working with those who hoard. I try to really take an opportunity to discuss in depth with clients and co-construct goals together. So if a client then starts to show buy-in as a stakeholder, that, okay, this is the goal that I'm willing to do, this is what I'm going to work on. If, for instance, we've identified those goals, and then the client isn't coming to those goals. They aren't able to successfully make them. That's when we start to think about, we go back to our social work toolbox, think about the process of partialization. So breaking down goals into more comprehensible ways, right? So it could be easy for us to say, okay, this is an overarching goal, we got to get there. But what are some of the barriers to getting there? So that means we need to break it down into much more manageable chunks. So starting to think about SMART goals, starting to explore barriers, starting to think about motivational pieces. So we might use motivational interviewing in tandem with, in terms of moving forward. So there are a lot of pieces there to dissect, but I would really encourage that there's a strong discussion around what steps need to happen and someone's actually buying into those, rather than, okay, what are you going to do this week? I'm going to clean up my room. Great, I'll be back next week and let's see how you've progressed, right? That's too subjective, it's not measurable. But if we could break it down into thinking about what are those problem areas that the person really identifies as being highly problematic? Let's say the dining table. The full dining table might be too tough for someone to tackle right away. So what if they start working on just a section of the dining table? And this process happens after you've actually worked with the person around truly sorting and starting to really develop those skills, rather than, okay, sort, because it's still going to be difficult. They don't know how. That makes sense.
Mhm. So I guess then my follow-up question would be that there could be a point, or could there be a point then where even when you do all those things and really break it down and make it much more manageable, like the process,
Mhm.
if it still isn't happening, then all right, then that indicates that you need to they need like a referral out or some like time to bring in other professionals, other resources to actually address the issue.
Usually, yes, that can certainly be it. I would highly encourage therapeutic support, if that's available within your region. So connecting the person with a therapist, right, may also be connecting them with other vendors like Heavy Chore, for instance, or professional organizers. But I would not jump automatically to the physical help without understanding a little bit more around the thought processes. So that's where the therapeutic intervention would be pretty helpful, because if there are so many barriers, the person understands that this should happen in theory for, say, compliance reasons, that there is this lack of motivation or willingness to move forward. That's when you have to really start thinking about, well, what is this person presenting with? What are the primary presenting concerns? And then taking a step backwards from there, thinking about, does this mean I need to then connect them with the most appropriate resource?
Thank you.
That makes
I have a
sense.
question if we still have time for questions. Is that okay? Okay. So I'm an occupational therapist and a social worker and practice primarily as an occupational therapist. And I'm really intrigued about this idea of hoarding as an occupation. And your talk has been great. Thank you. When I look at some of the things you mentioned as far as behavior mod, increasing awareness and strategies, do you think there might be room for collaboration between OT and social work? And OT also has some behavioral management strategies that we can provide as interventions, but I'm particularly interested in maybe using alternate occupations as a strategy. So once it's identified, maybe what need is being met through the hoarding, having OT participate in identifying alternate occupations that won't be as, that won't negatively impact health and well-being. So just curious on your thoughts about that.
I'm so glad that you're saying this or asking this question, Stacey. I myself personally have not worked with OTs just because perhaps of availability in terms of where I'm working primarily, but I do highly encourage a multidisciplinary approach, especially for crisis cases. Okay, so if someone is facing a lot of risk and within a finite period of time, we have to think about, well, who does the resident interact with? And then if we're developing a team, right, because it takes more than one person to just move forward with this. Number one, the client needs to be the number one priority. So they are a team member, never having team meetings without the client present. But now thinking about who else might be involved. Is it a police officer who first came out or does a lot of ongoing visits? So I do a lot of trainings for law enforcement. Animal control, if we're thinking about some animal welfare issues within the space. Protective workers, a case manager, resident service worker, a landlord, inspector, code enforcement. So the list can be rather lengthy depending on the case. So of course, it's rather individualistic to what's going on with the case, but in short, I would say absolutely. I do know that as a profession, OT does incorporate a lot of those elements that I was referencing throughout my presentation today. So I can see how it would be very helpful to work jointly with OT.
Thank you.
Okay, and then I see that Shelby wrote that at one point they were working on a case and fire department was a key player. That's huge. I like to talk about that, especially when thinking about harm reduction and the use of the uniform inspection checklist. I like to, as I'm doing an assessment with a client, use very descriptive language. So you can imagine that as I'm walking through a home and walking through that checklist with the client, and I say that there's a need for at least one obstructed window in any given room. And the resident might state, yeah, well, the windows may be blocked, but that pathway's open, right? So then I try to say, well, think fire, right? Think fire. So what if a fire was obstructing that path and your only means of exit were to get out of that window or someone to come in through the window to rescue you or anyone else who might be in the home? Think about that. 24% of all fire-related deaths that are preventable are related to hoarding. Okay, so that's a pretty staggering number. So I try to think about that and think about how to best use the resources within my area. Fire can be a huge component.
Great, Eileen, thank you so much. I know so much of what you said resonated with folks on the call, so I appreciate you sharing your perspective and sharing the information with all of us.
Thank you all for having me. I really appreciated this.